Hello, everyone. Welcome to Grand Rounds. Today, I have the pleasure of introducing Dr. Bukusi. She is the Senior Principal Clinical Research Scientist at the Kenya Medical Research Institute, KEMRI, and Research Professor at the University of Washington, with additional faculty roles at Aga Khan University, Maseno University, and the University of California, San Francisco, and Amref International University, AMIU. She co-founded the KEMRI Research Care and Training Program in 1995 and leads the Bioethics Program at AMIU. Her work spans socio-behavioral and biomedical research, HIV care, and capacity building, with a strong focus on research ethics. She is the founding chair of the Bioethics Society of Kenya and has held leadership roles with the AIDS Vaccine Advocacy Coalition, the WHO Human Reproduction Special Program Alliance, and the HIV Trust. Everyone, let's welcome Dr. Bukusi to the stage. Thanks so much.
Well, good morning, everybody. It's a little bit intimidating after you've just been introduced so eloquently that it's always a lot harder to be able to live up to your reputation. But I'd like to first say that it really is a great privilege and joy for me to be here today and to be talking to you this morning. Let me start by saying I come from a country where we are known for many things that are good, and a few things, unfortunately, that are not as good. But let me start with the good side, and that's why I chose to make my talk be about the Big Five. Because among the things that we are known for in Kenya is the wildlife that we enjoy and that we are very proud of. We are also told that Kenyans are really, really good at running marathons. I, unfortunately, are one of those Kenyans that even if a lion was chasing me, it's very unlikely that I would win any marathon. But I'm proud of my countrymen and countrywomen who do win marathons world over. Kenya is also a country that's right on the equator, so we have the joy of having weather that's pretty standard and pretty similar, with sunrises and sunsets literally at the same time almost every time of the year, and really, really temperate weather. But we're also known for many other things, apart from the Big Five that I will sort of talk about, and apart from the beautiful things that happen in Kenya, we have also been in the top 10 of countries that have been ravaged by the HIV epidemic and have seen many, many of our citizens, unfortunately, yield and die as a result of this epidemic. But I want to talk a little bit about, not just about HIV, but I want to talk about sexually transmitted infections. Because often when we talk about sexually transmitted infections, we forget that, yes, while HIV is sexually transmitted and there are other means of transmitting HIV, but it has brought to light other concerns about sexually transmitted infections that have been of concern for someone like me. Maybe let me start and tell you a little bit about myself, because it might help you understand the context that I'm coming from and that I will speak to. I am trained as a clinician and obstetrician gynecologist with training in public health and subsequently training in bioethics as well. But I've also had the privilege of not just being trained in my own country, but also being trained here in the US at the University of Washington, where I'm also affiliated. That's where my professorship is from. But in the 30-odd years that I've worked in this field, I've seen many, many shifts. And I want to start by telling you a story about the things that I've seen in the process of working in the field of global health, reproductive health, and particularly sexually transmitted infections and HIV. When I was a scholar and in high school, one of the poems I learned was about a young woman who was called Atieno by the poet who wrote it. And she described a situation where young women would come into situations where they would work because they didn't have adequate education, so they worked as nannies or as house helps, had very little food, very little lodging, and as a result of lack of education, would often end up getting pregnant at a very early age, and because of lack of access to healthcare, would often die from complications of reproductive health concerns like postpartum hemorrhage. My country has been independent for 60 years. Unfortunately, we still see similar trends today. But the challenge today is the girl who was called Atieno 60 years ago when my country was getting independent, who died of postpartum hemorrhage, now will not only die of postpartum hemorrhage, she's also likely to be HIV infected, but then some of her colleagues are likely to end up with sexually transmitted infections and not even get pregnant because of the sequelae of HIV. So this is the context in which I work, in which we have been noting there's a high and rising burden of sexually transmitted infections that are actually curable. And we know that this has a relationship with HIV. Unfortunately, many sexually transmitted infections not only go undiagnosed, but as a result, they're also untreated because they are asymptomatic, largely among women. And there are severe sequelae, especially for young girls and women. Historically, sexually transmitted infections have been underfunded, and the recent shifts in policy make them even more at risk. Why should I be concerned about sexually transmitted infections? Because we've been able to note that even in studies that primarily are not focusing on issues of sexually transmitted infections, that we are picking up very many sexually transmitted infections as a result. If you look at the STI burden in Kenya as depicted in these studies, and you can see overall about 62 different studies that have been done over the last few years, some of them focusing on female-only populations, some of them focusing on general populations, some of them focusing on male populations, that we can see there definitely is a concern about the numbers of different sexually transmitted infections. So how has this evolved? As I said, historically, sexually transmitted infections have been underfunded. Now, in the early years of my own work, and what brought me into this field as a young woman who was interested in obstetrics and gynecology was pelvic inflammatory disease. And at that point in time, we actually were concerned about women who were living with HIV and wondering if they ended up with pelvic inflammatory disease, could they be treated in the same way? Or would the standardized treatment not necessarily treat them or allow them to be able to recover well? Now, as we started focusing on the issues of HIV, then in a sense people forgot about other sexually transmitted infections. And it actually has only been in the wake of pre-exposure prophylaxis that the concern has now come up again about sexually transmitted infections other than HIV. I have been fortunate that I was part of work that was done, even including early HIV PrEP studies among discordant couples, among young women, and that we've been able to then show that pre-exposure prophylaxis for HIV does work. When people do take the medication, they actually are able to protect themselves. But in the wake of this, there has been a lack of diagnostics, a lack of innovation, and the HIV infrastructure has been able to actually support STI testing, but again, this has not been a focus. So what have we done in as far as sexually transmitted research in Kenya has been concerned? Essentially, those of us who have been working in the field of HIV have used the infrastructure that has been developed and that was generously funded for very many years by the US government through the PEPFAR program to ensure that under this platform, a lot of work could be done and could be advanced to look at sexually transmitted infections. So many of the sexually transmitted infection research projects have been secondary or tertiary aims for projects that are primarily focusing on issues of either HIV prevention or HIV care. And the funding streams that have been available in the past have definitely contributed to this. But while sexually transmitted infections have built on this infrastructure, unfortunately it has still remained rather vulnerable and has been really hit by the shifting donor funds. Let me show you a map of Kenya and just show you on your, I believe it's also going to be your left, you can see in the darkest areas. This is actually, and I don't know whether this pointer is going to work. I should have checked on it earlier. Oh, it does work, but this area here, and this is where my own research work is focused, the darkest area is around Lake Victoria. Kenya has the smallest part of Lake Victoria that is actually shared between Kenya, between Uganda that's here, and between Tanzania that's here. We have the smallest part of the lake. But around the lake here, a number of different things have been contributing to the fact that we have such a high HIV prevalence. Primarily just lack of infrastructure, lack of care, but also populations that have largely had men who are not circumcised, and then cultural and other social factors that mean there's a lot of crisscrossing around the lake, so that if one particular country doesn't have its STI and HIV under control, it's very, very easy for, as we talk about it, this to go across the borders. So this is the area in which I work. But similarly, you can see, when you think about the STI research sites, they really are focused around the areas. This is actually around Nairobi. Nairobi is our capital city. Around the coast, Mombasa, where we also have a lot of port activities. So what are we concerned about when you think about the global policy and priority shifts around HIV, and how would this impact STI research? We've seen reductions world over, not just from the US government, but other funders have also, as a result of shifting, because the US government's funding was not only for low and middle income countries, it also funded other high income countries who worked in collaboration with many US scientists. And then the current conflicts that have been ongoing have definitely also taken their toll. And then there have been other competing priorities. The COVID pandemic that we have just come out of, other concerns around issues of climate change, and then non-communicable diseases have also been a concern that have shifted priorities when it comes to issues of infectious diseases. How this has affected us in Kenya? Because of the focus on HIV and HIV care for many years, there has been a lack of attention to both human resources and even the question of just burnout from health workers being overloaded. There has been a challenge with issues of ensuring that we can have adequate testing and testing programs, because many of these were supported, that basic infrastructure, by the HIV care programs that were running. Because of the pandemics that have just happened, like COVID, there's a lot of distrust among communities, and this has actually interrupted a lot of the ongoing programs, both for sexual and reproductive health and HIV care. In a country like Kenya, we do have very big gaps. I think some gaps that you also see in some areas of the US, where there is a shift and there is a difference between access to care, whether you're in the urban setting or whether you're in the rural areas. There also is a concern about populations that tend to be stigmatized and tend to be marginalized, and who have much more difficulty in being able to access care. So these underserved communities and populations continue to be a nidus where infection may continue, and they end up being disproportionately affected. So what are some options that I want to be able to suggest? And this will then now take us to the discussion about the Big Five. I think we really need to think about how we work together as a globe, and recognizing that indeed, as the COVID pandemic did show us, that because diseases know no borders and know no boundaries, unless we really work together, it's very difficult for us to achieve health that we can consider as globally available and accessible for all in this current era. We do need to think about what can we do to be able to ensure that we can adequately test and treat. How do we adequately diagnose? Thinking about scaling up rapid and affordable diagnostics that can be made available, not just for people in low and middle income countries, but for people everywhere. And to do this, I think we really need to strengthen our global partnerships. I'm convinced that collaborations are one of the key things that will really help us to be able to think about how we weave sexually transmitted infection research within the ongoing HIV care and prevention programs, even as they shift, and that this will allow us to be able to continue to do good work, even in the wake of the challenges. Which brings me to my Big Five. I know many of you have thought about elephants, and you probably get an opportunity to either see them in one place or another. And we always wonder, so what's in a name? What does it matter? Elephants are known to be very matriarchal societies, and continuing research shows just how linked they are and how well they work within their own family groups. They're also known to have very long memories, and that they pass on information from one generation to another. One of the key areas, and my first big one, is about human capital development, making sure that we have strong mentorship streams that continue to involve others. I was mentored by, among others, the late Professor King Holmes of the University of Washington, who has done a lot and did a lot to actually destigmatize and focus work on sexually transmitted infections. I was part of the people that he poured his life into, and as a result, I have had the opportunity to work with others. Professor Thomas Adenyi, who's now here in the audience, who's part of the reason that I'm here at WashU today, has been one of the individuals that I have had the privilege of working with and see grow into his own space and become a global health leader in his own right. I've had the opportunity to work with others who have worked on many important trials that have informed the situations in global health. Dr. Marciano Nono, who's been leading our Kenshi trial that have been able to clearly demonstrate that a once-only HPV vaccine is adequate to be able to prevent and support young women from developing cervical cancer when they grow on. Dr. James Ayeko, who's right here next to Prof. Thomas, is one of the individuals we're working on the search trials. The search trials, led by Dr. Diane Havler of UCSF, have been able to demonstrate the test and treat as a really good option that allows us to be able to ensure people get care when they need it. Among the young researchers I've been working with currently, Victor Omolo, Dr. Felix Mogaka, and Janelle Stewart, who've been able to do work on sexually transmitted infection, thinking about doxy-PEP among women as a means of being able to reduce sexually transmitted infections among women who are already taking pre-exposure prophylaxis for HIV. The cheetah is known as one of the fastest animals, really, really fast. But you know, one of the important things you need to know about the cheetah is that it cannot keep up its speed for long. It has to have skill and strategy. If a cheetah does not catch its prey within a few minutes of its takeoff that goes from 0 to 100 kilometers per hour, it has to stop. Because its heart is very small, and the amount of blood that it has to pump in order to run at those speeds cannot be sustained for long. It's not a marathon racer. It is a sprinter. So the question this brings me to is always about, in order to have skill and strategy, what do we need to do? Collaboration means that we also need to think about the infrastructure. I know that many of the US universities right now are going to be struggling with the issues of the overheads, because one of the things that has helped build the US universities and allowed them to have the stature and the work that they do is ensuring that they put back the money that they get for research and other activities into building infrastructure that helps them be able to do the work that they want to do. So we were able to embed infrastructure within the public health facilities so that they could be used for good. And we had the fortune of being able to work with individuals who believed in the work that we did and were able to support infrastructure development. This has been the bedrock of our work, because you cannot do good work if you do not have good facilities in which you are able to do them. So collaboration means not just thinking about ourselves, but also thinking about where we work and how do we build up infrastructure that is able to sort out and help us get the work done. A few years ago, I had the privilege of visiting South Africa. And when we were in South Africa, one of my colleagues convinced me that we should go on a game safari. On this particular game safari, what was required of us was to be able to walk. We were not in a car, we needed to walk, and it was supposed to be relatively safe. The game ranger told us that in order for us to be safe, all we needed to do was to make sure we walked behind him in a straight line. He actually carried a gun, but he told us that he rarely had to use it. And the gun was really more to be able to scare away any wildlife if really they did come after us. He did tell us that in the event that we met any wild animals, he required us to stay in a straight line, stay behind him, and he would take care of us. We were asked to walk quietly and silently so that we respected the animal's space, so that we would get a chance to see them. We all listened, we all agreed and said that we would follow the instructions. So we went along. Now, as we walked, and it was relatively nice, relatively quiet, we got to a place where suddenly, from the thicket, a rhino charged. Now, the rhino wasn't actually charging at us. We startled it, and it became afraid, and it ran out of the thick grass. Now, guess what happened to the 10 or so of us who were behind the ranger? Did we remember to stand behind him? I can assure you not. We scattered in all different directions. Even as the ranger kept shouting, "Stand still, stand behind me." We honestly all ran. Even the couples who were there together, nobody thought about the other. Everybody took off in a different direction. It's probably not the kind of safari walk you want to do if you're on honeymoon, because your marriage might end very quickly. But the rhino reminds us, because it does charge. And one of the reasons the rhino charges is because it doesn't have very good sight. But they say that if a rhino is running towards you, run and then take a sudden step and it will go past you. It's unlikely you will ever remember such instructions, and you'll even wonder who gave them to you and if they ever followed it themselves. But rhinos do commit, and once they commit, they charge. My third big five is around research and policy. Research is not just done for the sake of research. Research is done so that it can make a difference, so that it can help improve something. It can help improve the lives of people when you're talking about working in health. And again, I've had the privilege of being able to work with the ministry in moving research from just research into policy and into practice. We've been able to be part of not just the HIV prevention guidelines, but also the HIV treatment guidelines that have helped improve and save the lives of millions of Kenyans today. So let research be something that you can commit to and that you can charge, that you go the full way, that you don't just get the research done, but that you move it on into policy and, if possible, into practice. My fourth one is around leadership and mentoring, because these are the bedrock on which research will be able to make a difference, whether it's sexually transmitted infection, cancer research, whether it's implementation research, whatever it is, leadership and mentoring are very important. Now, the interesting thing about lions is, even though we talk about the majesty of lions, and we always look at the big picture of the male lion, strong, the reality is male lions are very dependent on the female lionesses. The female lionesses are the ones who hunt. They are the ones who bring home the kill. They are the ones who keep the groups together. And even though we talk about the lion as being the king of the beasts, we know very well that they are dependent on others. So mentoring is not just about who you are and what you're doing. It's about who are you building and who's going to continue the work when you are not there. For every leader who doesn't have others who are working with him or her, your work will not go very far. You will only be as good as those who you are able to mentor, and you'll only go as far as those who you are able to walk with. So we need a very strong research ecosystem. We need research capacity that's built over the years and that's able to be resilient, that's able to diversify when they're looking for funding, and that are able to build on improving research capacity. We have to be able to work with younger people, people who are innovative, who bring new ideas to the table. I'm now in my 60s, and I know I'm pretty set in my thinking. I don't have big, fresh ideas. When I think, I probably am very limited in the things that I think about. But when I work with other individuals who are younger, who are not afraid to think out of the box, who are not afraid to dream, who are not afraid to think the sky is not even the limit, then I get the opportunity to be able to truly expand my own research field. We all need accountability. Buffaloes are some of the most dangerous animals you would come across in the East African ecosystem because they work together as a herd. And even big hunters like lions can only hunt the buffalo who is estranged and removed from their group. When they're together, buffaloes will kill lions. When they're together, buffaloes will intimidate elephants because it's very difficult to destroy a herd. It's very difficult when people are in community and are accountable to each other and responsible. It's very difficult to break those relationships or to stop the work from moving forward. This is the last of my big five. We need partnerships that are sustainable. We need networks that work. Those of us in the southern part or in the low and middle income countries need to work with those of you in the global north and those of you in high income countries. We need each other. It's not about one group, it's about all of us together, because we are in a global village that really is very small, And it's only by working together that we would be able to make a difference. I want to end in the next few moments by just sharing some of the examples of work that we have done related to sexually transmitted infections that I hope will illustrate the 5 big points that I've made around the big 5. And I want to start with the issues about just thinking about examples of sexually transmitted infection research within HIV projects. Starting with the issue of being concerned about thinking about sexually transmitted infections and thinking about how can we ensure, as we work on HIV prevention, that we also stop other sexually transmitted infections. We know chlamydia and gonorrhea lead for young women when undiagnosed, undetected, untreated to infertility. Even when women get pregnant, premature deliveries and other complications arise because of sexually transmitted infections. So being able to look at this becomes really important. With Connie Kellam at the University of Washington, who looked at a powerful options, a study we called POWER, Prevention Options for Women, really looking at how could we evaluate differentiated PrEP delivery models to be able to provide options for women. In this particular population, we found very high STI rates among young women who already recognized they were at risk enough because they were coming in for pre-exposure prophylaxis for HIV. With Dr. Jessica Haber, we've been looking at how can we find more mechanisms of delivering pre-exposure prophylaxis. Young women don't like to come into healthcare facilities. Healthcare facilities are for people who are unwell. People who are well don't necessarily want to come and queue up. They don't necessarily want to come and sit. In addition to that, for young women, they don't want to be seen in those places where someone else may recognize them and then question why they're there. So thinking about how do we deliver PrEP by peer models into communities where young women can access them and be able to have these services. But again, within that particular population, while the peer delivery model was very acceptable and very usable, and we didn't have anyone ending up with HIV infection, we had very high rates of other sexually transmitted infections. Post-abortion care is an area that we've targeted because any young woman who is pregnant, that is a clear indication that she had sexual exposure that was not protected by condoms or not protected by contraception. So that is a high-risk group. And unfortunately, for many young women, this will become repeated, that one loss of pregnancy, abortion, and exposure to sexually transmitted infection may mean another opportunity for getting other sequelae of STIs. So this is an area where we also looked at what was their interest in being able to accept pre-exposure prophylaxis and also looking for opportunities to test for sexually transmitted infection. You can see the very high rates of chlamydia among these young women in all these different studies I've been able to demonstrate. Going out of the healthcare facilities, we thought about, so where can we provide PrEP? Where do women go? Where do individuals go for care when they don't go to healthcare facilities? Our community-based pharmacies are where most people go for their first level of care because they're available, they're ubiquitous, they're all over. The pharmacist is an easy person for someone to go and ask, I have this problem, I have this headache, I have this discharge, what would you give me? And while technically the pharmacists are able to dispense and not necessarily prescribe, we know that in many places they provide prescription medications, even though technically it shouldn't happen because the supervision and the oversight is not as strong as it should be. So we've been delivering PrEP, pre-exposure prophylaxis for HIV, as a pilot and as a test and in a study to be able to see whether this is a place where adolescent girls and young women and young men can access not just contraception when they need it, which is available, but also pre-exposure prophylaxis. But again, as you can see, high levels of chlamydia trachomatis and also gonorrhea. So what is the point that I'm trying to make? The data has really shown us clearly that sexually transmitted infections are a concern. It is something that we needed to be able to deal with for its own sake, but also among those who are seeking pre-exposure prophylaxis. So I'll tell you a little bit about a study that we did to be able to see, because doxycycline has been able to be shown as doxycycline PEP has been able to be shown to be very effective among men who have sex with men. But the question is, for young women for which the sequelae are even more severe, was it possible for them to take doxypep as a way of preventing sexually transmitted infection? So in the first study that we did, that was funded by the NIH, we were able to have young women who came in who were looking for pre-exposure prophylaxis for HIV, and were able to put them either into an arm, where it was a control arm, or where we treated them after syndromic management or symptomatic management, and those who we randomized to doxypep. Unfortunately, when we did analyze, we showed that there was no difference among the control arm and those who are actually supposed to be on the doxypep. This study was conducted during the time when the COVID pandemic had just happened. That's when we're beginning this study. And when we eventually looked at the hair samples to be able to test for doxycycline, we found only less than 30% of those who reported they were actually taking the PrEP were actually taking it, meaning it didn't work because it wasn't taken. And we've known that from very many previous different live types of work. When people don't take PrEP, it definitely does not work. So it made us think about, can we do a proof of concept study? Because we actually thought that perhaps if we were to weekly dose with 200 milligrams of doxycycline on the same day each week, sort of going on a DOT model, observed therapy, just like had been done for TB, would that be an opportunity to provide a combination of PEP and PrEP coverage so that any exposure that happened 72 hours before the first dose would be covered? And then the vaginal levels should be enough to be able to protect them if they had exposure thereafter. This was actually a very small study that we did just in very few women, but we were able to show among these 60 women, using a standard of care control that was similar, the study that had been done earlier, that when we did a doxy-DOT study, where we had observed therapy, initially, individuals would choose whether they wanted to come back into clinic, whether they wanted the dose delivered to them at a place that was convenient to them within the community. We're actually able to show that indeed doxypep does work, and we're able to reduce the incidence of chlamydia among these particular women. Remember that we're not looking at the issue of gonorrhea because this has been already shown that there's a high level of resistance, so we weren't targeting gonorrhea in this particular case. So we're expanding our care and starting to think about what are the opportunities for diagnostics. And some of the team that I've been working with are collaborating to be able to think about how can we find new ways of being able to do point-of-care tests to ensure that we can actually diagnose sexually transmitted infections and therefore be able to treat them. So bringing it all together, what is my big five? Even as we expand and continue, hopefully, to expand HIV care, and as we try to ensure that we are preventing new infections among those who are at risk, my hope is that we can still focus on the issue of sexually transmitted infections because of the concerns that it causes in the reproductive health field. We know that our current challenges are not just for us alone, but they're challenges that people face globally. And we know that when there is a neglect, that the chances of resurgence of sexually transmitted infections and the momentum that we've gained even in the wake of the HIV pandemic that has been brought under control will be lost. I think the big five that I've shared remind us that when we build capacity, we build it not just for ourselves, but we build it for the future and for making a difference in the work that we want to be able to do. I'm hoping that the collaborations we are developing in the past and the ones that we're developing now, even with WashU, will be opportunities for thinking about integration, service, product, and even pushing things into policy that would make a difference, not just for those of us in Kenya, but even for those of you who are here in the US. So my last call is really to think about, can we maintain and can we grow collaborations that will continue to allow us to do the work we want to do globally? One of the things that I've been very happy about is the opportunity to have had really excellent teams that I've worked with, of young, excellent scientists who will definitely go far, even beyond where I have gone. And my last picture here is one of a climb that we did in 2009, where I had part of our leadership team climb Mount Kenya to the third highest peak. Mount Kenya has 3 peaks. It has Batian, it has Nelian, and it has Lenana. Lenana is a long hike. a very long hike that is challenging because it is snow, and despite the fact that with this mountain is right at the equator, we have snow at the top of it. So we were able to set a record where we had 72 of our team members climb right to the top of Lenana, a hike that was quite challenging. The lower picture here shows when they're actually at the top, this is where it is, and you can see how cold they are. Everybody's all very bundled up. But the beauty of the climb was not just getting people to the top, it was an opportunity for the leadership levels to show. There's nothing that brings out the best in a leader as when they are tired and hungry and nauseated and also have mountain sickness to deal with, as to whether they're only going to think about themselves or whether they'll think about the person who is standing next to them. Thank you very much for your time and for your attention.
Stay, come back to answer questions. We have time for a few questions.
Wonderful talk, thank you. Just curious if HIV drug resistance is a problem, and if so, are there not medications to manage that issue?
And could you repeat the questions so that on the recording?
Yes, I will repeat. So the question is about whether HIV drug resistance is a problem, and if it is a problem, what we are doing about it. We think that it is a problem, but not as big a problem. But again, we have been monitoring it. But again, we're coming back to the issue of funding. We did have some very good funded programs under USAID that were helping the NASCOP, the National AIDS and STD Unit at the Ministry of Health, be able to track resistance. But with the funding decreases, it means that the Kenya government is going to have to take it over, and that hasn't quite happened. I think part of the challenge has been not so much the taking it over, but the abruptness. I think there had been plans, medium, long-term plans for governments to continue to take over, and as PEPFAR was slowly pulling out, governments were starting to own their programs and be able to fund. But I think the abruptness has resulted in some disruptions. So we do have a concern, but it hasn't been as big a problem.
Mark?
Thank you, Dr. Bukusi. It was a terrific presentation. You talked about collaborations with other academic institutions. Can you talk about, as you said, this sort of abrupt change, diversifying funding, like what potential collaborations might look like with the private sector, or how, you know, the technologies and innovations that you and your team have developed? Is that something that you're seeing starting to grow, perhaps?
So the question is around, even with the reduction of funding and so on, are there collaborations that are happening, public-private partnerships? Are we seeing that starting to grow, and are there opportunities to expand that? I would say that it's early days yet, but it is starting. I think one of the challenges has just been that with the reduction of the US funding, the other countries that have also been funding research are feeling it. So it's not just the US. The UK is reducing its funding. Europe is reducing its funding. So it's like, because the US funding was not only coming to low and middle income countries, it was also a benefit to countries in Europe and in the UK and everywhere else, and even, you know, Asia. So with that reduction, and with countries starting to look more inward, it means everybody is cutting down on their funding. The European Union, through EDCTP and other EU mechanisms, has sort of been trying to step up. I think foundations like the Bill and Melinda, the Gates Foundation, are also trying to sort of step up, but it is a big gap. It's very hard to beat government funding, regardless of how much private funding there is. What we've also noticed, I think, in the last couple of years is pharma is trying to step up. I think because they are also seeing the gap, but because of their own interests. But the challenge with pharma is there's always stipulations at some places, and they give much less flexibility, and they tighten the ropes a little bit more. So there's a little less academic freedom, a little less exploration, because you have to be interested in what the farmer wants to do in order for you to be able to work with them. But in that opportunity of diversifying funding and looking for other opportunities, yes, that's definitely arising. And I think for many of the US institutions and universities that have been working globally, the same issue, I think, will keep rising about how do they diversify their own funding in the wake of the current challenges. But I think the onus is also upon us who work in this global field to be able to show how does that benefit not just the countries that you're working in, but how does that benefit the USA? What work are we doing globally that does actually translate to a person who's paying taxes in the US saying, this is to my benefit. I am also a beneficiary of this work that's being done. And perhaps it's also for us scientists not to assume that people know what we're doing and to be able to be more vocal about making it clear what we are doing and why we are doing, and communicating in a way where people can understand us, not just in our beautiful journals and with a jargon that we love so much.
So the work that you're doing mostly focuses on women and adolescents, young women, in a targeted way. Are there any opportunities to do men and women together, or culturally is it so separate that the best strategy is separate?
I chose to share about work that is about young women, and because I'm a gynecologist, I think about young women, I think about women all the time, but I think about women because I think thinking about women also thinks about men, because for me, it's a whole ecosystem. But no, we work in very many fields. I could have talked about voluntary male medical circumcision that we have been part of. And actually part of my early work, and I ended up getting dubbed the one scholar my late mentor, King Holmes, had for many, many, many years wanted to do work that made, to sort of understand bacterial vaginosis. Bacterial vaginosis it's really a shift in the microbiome of the female vagina. And for a long time, he had had this premise that it is men who would carry microbes back and forth, not necessarily sexually transmitted, but just carry them. And he had this idea that especially men who were not circumcised, that they would carry a lot of these anaerobic bacteria under their subprepuce and be able to transmit them. And so he had tried for a long time to get scholars to do work that would try and convince men to think about uncircumcised men to wash before and after sex, to see whether that would reduce bacterial vaginosis among women. I was the first scholar he managed to dupe and convince to do that particular work. So I got dubbed the Willy Wash champion. The work we did in that particular field, and that was just before male circumcision then, picked up and did show that, yes, it does make a difference in terms of acquisition of HIV and even transmission of HIV one way or the other. But in the work that we did then among men, very interesting, we were asking all kinds of interesting questions. And men, particularly around the fishing communities, and we would ask them questions about their hygiene and about their change of underwear and so on. And I remember one man looking at us and saying, why would any man have more than one underwear? Why? And we sort of looked at him in shock, like said, but he was like, no, but you wear it, you wash it, it dries, you put it back on, and life continues. The people who should have many underwear are women. So yeah, there are many cultural issues around there, but our work has been about both men and women. But the reason we focus on women and young women is because that is the face of the HIV pandemic for us. It is a young woman aged between 16 to 24. That's where our highest risks are. And because we know that unless we do something about that population, we cannot have a generation that will be HIV-free, because those are the young women who are going to bear children. And if they get infected, the possibility of children who are born with HIV or infected just become higher. So that is the reason why we focus on that very vulnerable group of people, because they also have many structural and many cultural and other barriers that put them at risk, including lack of education, opportunities for advancement. We know that you keep women longer in school, it's just beneficial all around. And while many people will still culturally focus on educating the boy child, many women do not have such opportunities. Yes, there's now counter-arguments to say the boy child has been so ignored that we now need to be concerned about the young men, but the young women still remain distinctly at a disadvantage.
Thank you. Other questions?
That's such a great goal. My question is, in this great work, how did you address the stigmatized population who are afraid of not willing to participate or that's based on the stigma in your community?
The question is around stigma in this work that we're doing. How do we deal with the issues of stigma? So one of the things that really was a game changer in as far as HIV is concerned is the availability of treatment. Because when HIV changed from being a death sentence to being a chronic illness, that made a difference. I was a fourth-year medical student when HIV was first diagnosed in my country, and in those days there was so much fear that people didn't even want to walk into a room that had a person who was HIV infected. And for me, one of the things that shaped my career and made me come into this field was a young woman whom I met. She was HIV infected, she was wasted, and she was essentially dying. And we did not have treatment, and there was nothing we could do. And when people died, when they were HIV infected, we wrapped them up in big black plastic sheets of paper because everyone was worried about contagion. And I remember talking to this woman and asking her, what did she wish for? In my young, naive mind, I thought she would tell me she wished there was a cure, she wished there was treatment. And she said to me, I wish I could have a meal, and I wish I could feel full. At that point in time, she had such bad oral candidiasis that she bled from literally every single part of her mouth. She couldn't chew because it was so painful. And anything she ate literally came out the way it was because her digestive system was so impacted. And her only wish was just to be able to have a meal and feel full because she knew she was dying and she knew there was nothing we could do about it. But for me, she remained an inspiration to be able to say, how do we make a difference? And the issue of stigma was partly addressed when we started being able to provide HIV treatment. Because then the faces that had been the face of HIV, the ravaged, emaciated, thin, dying person, was no longer the person who walked on the streets. It was an opportunity for people to choose to get tested, but you can't look at my face and decide that I have HIV. So that was one of it. The second was really being able to embrace and recognize the fact that being HIV infected is not a death sentence, and neither is it an indictment to say what you've done or what you haven't done. It's just you happen to have an infection. But that doesn't define who you are or what you're capable of doing. So helping turn the tide in that way was a way to start to bring people and to allow people to come into the space of testing. And then saying knowing your status is an important way of making decisions. Once you know your status, you can make a choice about treatment. Once you know your status, you can also make a choice about how to stay uninfected. So bringing a positive look to it rather than a negative defining way was a way to beat the stigma.
Angela?
Good morning. Thank you for a wonderful presentation. I was really struck by the analogies with the Big Five and understanding that the animal kingdom understands community engagement. And that said, from the standpoint of teamwork, you talked about the pharmacists, and clearly they're trusted partners because, they're trusted in the community because they're readily available. Has there been an attempt to really actively engage the pharmacists when it comes to education, being aware of the trials and the studies that are available so that when folks do go into the pharmacy, you can make sure that they're giving accurate information and then also directing them, the patients, the people, to the right place to get either screening or treatment or whatever's needed?
That's an excellent question about engaging pharmacists and how we can make sure that because pharmacists are trusted and are available within the community, that they can be part of or provide care. And that's the reason we've been doing the work about delivery of pre-exposure prophylaxis among pharmacists, because we're responding to a need that the Kenyan government had recognized and said that they wanted to be able to see, can it work? Is it a place people will go to? And then being able to see what amount of time does it take? What kind of remuneration would the pharmacists need to be able to take on this work? Because many of these are commercial enterprises. They are not government-related work. But if the government can provide the free antiretrovirals that are used for pre-exposure prophylaxis, will the pharmacist be able, at a small fee, $1 or $2, be able to be willing to provide this service? Because remember, there is the issue of testing before you're giving pre-exposure prophylaxis and making sure people are still negative, that we are not enhancing the concern around potential drug resistance by people who are already infected taking PrEP rather than getting treatment. So that's the work we've been doing, and indeed the government has been very interested in it. And the goal now will be to see how do we roll it out? How do we ensure that the pharmacists can get can ensure that they get training so that they are able, because antiretrovirals are still a prescription-only access. And are there mechanisms of creating remote physician oversight so that if there are complications or if there are needs that people need to have further testing or further evaluation, it's easy to be able to refer them for additional care.
Does there seem to be buy-in from the pharmacists for this approach?
Yes, there was definitely buy-in from the pharmacists. There were also concerns that they raised because it does take time. Not every pharmacy is able to do it because it means they do need to have space to have a private consultation, to be able to counsel someone and then have them tested. It means it does need pharmacists that have more than one staff. There are pharmacies that may only have an individual staff. They don't want to keep people waiting in a queue because, again, this is a commercial enterprise. The more people they see, the more pass through, the more money they make. Someone who's going to take you half an hour to talk to, counsel, test, and then give, to explain how to take the prep. In terms of what they're paying you, it's not worth 10 different customers who have come in and bought condoms or anything else, any other easy commodity that you want to be able to pass through. So that balance has been one that needed to be struck. But they're definitely interested, and we're hoping the ministry is picking it up and trying to see how can they implement this as a mechanism of being able to expand access to PrEP.
Thank you very much.